Thank you very much. We're going to be going to a live case from Singapore shortly, but before we do that, Dr. Ashok Seth, because of some prior commitments, we've rearranged the schedule just a little bit. So he's going to give his talk next for the next 15 minutes, and immediately after, we're going to go to the live case.
Let me just first say that it is with trepidation that I walk up to this podium to give a talk after my great friend Marty Leon. I mean, how could I actually follow Marty Leon to this podium? And yet, it's a pleasure to be here. It's a pleasure to have the TCT in India being well represented. And it's a pleasure to be at this meeting, which is growing by leaps and bounds. And I'm sure it's just will set the standards for interventional cardiology in this country. The topic of my talk today is the Medtronic CoreValve System, overview of the procedure and the results. And of course, my conflict of interest with Medtronic, the slide has got missed out, is that I'm a consultant to Medtronic. We all realize that severe aortic stenosis is a significant unmet need. Numerous aortic stenosis across the world, a disease of the elderly, and 30% of the aortic stenotic patients do not get surgical valve therapies, even though that is the most effective treatment till now for this disease process. We also realize that once these patients become symptomatic, the survival is limited, and truly between 2 and 5 years, majority of these patients would die. And thus, and keeping in mind that 30% of these patients are inoperable, we actually have a large population of patients who needs to be treated by other methodologies. The conservative estimates of the industry in India is that the total aortic stenosis prevalence, and I just think that these are just way off figures, but going by some derived data, it appears that at least 2,500 patients would require TAVI or are available for TAVI in this country per year. I believe that it could be much larger than that and that we don't have any good data to back this up. Well, going to this, the TAVI procedure, the first compassionate use, the first performance of the TAVI procedure was by a good friend Alan Kribbier on 16th of April in 2002 as a compassionate use in a cardiogenic shock patient who was denied surgery. That, I must say, was a very crude valve. The valve on the right side, which is the Edwards Sapien now, was a very crude valve in 2002 on a balloon-mounted stent with a tissue valve stitched into it. Alan Kribbier used it for that compassionate patient, but then this valve took much longer time to develop into something which could be used regularly in patients with severe aortic stenosis. I'm here to talk about the valve on the left, which is the Medtronic CoreValve, which is a self-expanding nitinol valve, as opposed to the Edwards Sapien valve, which is a balloon expandable valve. This is how this self-expanding nitinol valve sits across the aortic annulus and across the diseased aortic valve, anchoring itself in the aortic root in a manner such as this. It is a very clever design. It is nitinol and has an extremely good radial strength. The upper part of it has low radial strength. This stent-based valve is divided into 3 parts. The upper third, which has a low radial force, is mainly meant for orientation of the valve in the aorta itself and across the aortic annulus. The center portion has the high hoop strength. It is a supraannular valve. It is a porcine tissue valve, and it is designed in an hourglass shape so as to avoid the coronaries. The lowest part has an extremely high radial strength. It is the intraannular anchoring part of this stent itself, and the radial force of it is so strong as to try to decrease paravalvular aortic regurgitation to the least. It is a sheath stent, as you can see here. There is a sheath. It's easily deliverable. The sheath is withdrawn. The nitinol stent carrying the valve opens up, and that's how it gets deployed across the aortic annulus. Here's just a cartoon representation of this catheter going across the aortic root, across the aortic valve. It's positioned, and then the sheath is withdrawn. As the nitinol stent opens up, the valve gets deployed. There are a few advantages over a balloon expandable valve in a way that because it does not occlude the aortic orifice, it does not occlude the aorta, one can actually unsheath it slowly, have accurate positioning of the valve, and to some extent, in the initial few millimeters as the valve is unsheathed, it is positionable or repositionable in terms of accuracy of positioning. And that is what this demonstrates, that this valve can be repositioned as long as only a small portion of it has been unsheathed. And the other advantage is that many a times rapid atrial pacing may not be necessary in this, with this sort of a valve, as the blood pressure is normal even at the start of deployment, towards the end of deployment. It's only in the middle third of deployment that the blood pressure tends to fall, and certainly the valve does not occlude the aortic orifice in most of its deployment. Now, the history of this valve goes back to us in 2003 when Jacques Seguin, the inventor of the valve, who's well seen out here, he's a cardiac surgeon, when he invented the valve and was doing the animal experiments, he got talking to us about the first in-man proof of concept as early as that. We did go to France to do some animals, and that led to the first in-man studies, the proof of concept actually being done in India. We were involved in the first cases of this device. And this goes back to a very historic time on 15th April 2004 at the Ashok Seth Institute, when we deployed this first valve, which actually functioned in a patient with aortic regurgitation. This is a very historic cine angiogram, perhaps possessed by, I guess, only Medtronic at this time, and Jacques Seguin himself. This shows that crude device, a 24 French device going across the aortic arch, in a patient with severe aortic regurgitation. We looked around for patients who could otherwise have this arches where this device would travel because it was a crude device. You can see that we had to lasso this device from the left brachial so as to pull it away from the aortic wall and align it towards the center of the aorta to cross the aortic valve. The sheath has been withdrawn, which is great. It positions itself. It was the first time that we saw it actually happen in human, who then subsequently survived this procedure. This is nicely opening up, the screw device actually then being brought out at that time, and you can see that snare which comes from the brachial artery, which helps this device to come back and be withdrawn. And then subsequent injection into coronary arteries. This was the first time that we were actually demonstrating that coronary arteries could be visualized through this valve, and subsequent dye injection into the aortic root to a surprise showed complete treatment of aortic regurgitation. So that was very fascinating to watch it for the first time at the table. Of course, this device has progressed from the days when we used it first as a first-in-man device over the years to its present form. The catheter has improved from a 25 French, has progressed from a 25 French catheter to an 18 French device, which is what is an AccuTrack device, which is now used. It's an extremely trackable device. It is extremely deliverable, and certainly has made the procedure truly percutaneous, especially with the use of ProStar or Perclose devices. It has enabled this catheter to be positioned either through a direct aortic route or through subclavian route in patients who have diffuse peripheral vascular disease, especially femoral and iliacs, which are diffusely diseased or are not large enough for using an 18 French device. The valve now comes in 3 sizes. It came in only a single size earlier on, moved to 2 sizes, and more recently has been available in 3 sizes, covering annular sizes from 20 to 29 millimeters. And then we go on to doing the first cases and starting the first program in India on early this year. You're well aware why there was a gap of so many years. That was related to numerous regulatory issues, numerous medical council issues, other issues which were totally unfathomable till we found that there were still ways to go ahead with this device on a compassionate use. And we were the first ones to start aortic valve TAVI program in this country, 21st February, when we practically did it ourselves with minimal help from Medtronic itself, with a team coming across to help us sort of talk us through the procedure rather than do the procedure. A 71-year-old lady, one of the cases, a non-smoker who had a previous bypass surgery in 2007, porcelain aorta, severe calcific aortic stenosis with a moderate AR and a 0.7 centimeter valve area. She had a porcelain aorta and had earlier at that time of her bypass surgery had mild aortic stenosis or a moderate aortic stenosis which wasn't operated because of porcelain aorta. Here's some of the workup that we have to, very systematic and meticulous workup that one goes through with these patients. One goes through transesophageal echo analysis with these patients, aortic root, a coronary angiogram, aortic root angiograms with marker pigtail with meticulous measurements of the aortic annulus, aortic root diameters, the landing zones, meticulous assessment of coronary arteries, CT angiograms of the aortic root, and more recently perimeter analysis, which has become even more important than just aortic annulus sizing. So perimeter analysis is one of the very important measurements. CT angiograms of the aortic bifurcation as well as the femoral and iliac arteries, again for access site implications. Transesophageal echo to guide us about many of these issues. And here's the porcelain aorta. You can see this lady having porcelain aorta. This lady actually went on to a ventilator with heart failure 3 times in the prior 6 months before we could get a compassionate use approval from the Drug Controller of India to actually do this TAVI as a first case in this country. This lady had a great procedure. I mean, this is as we went ahead with this case, and the balloon burst resulted in a torrential aortic regurgitation on the table with a drop of pressures. However, we still went on to the very meticulous positioning of this valve. You can see the severe aortic regurgitation. The patient's pressures were dropping at that moment, but it was very important that you only get a single chance with these valves, otherwise you really fail and fail badly. And here the valve being deployed. And soon as we got the valve into position and released it, we were happy to see that the pressures came up and the valve function find was accurate. And this patient did well, went home in 3 days' time. In fact, these were some of our patients who actually are seen at the day 3 mobilizing and doing well. Must say that the TAVI program is a teamwork. It involves clinicians, interventional cardiologists, cardiac surgeons, vascular surgeons, radiologists, echocardiologists, and cardiac anesthetists. It involves imaging specialists. It involves technical staff, nursing staff, and administration, especially in this country, to actually do a good job. Just a brief word about the results. I won't take you through a lot of studies, but just to tell you that there's a whole portfolio of studies on with CoreValve at the moment. Most importantly, there's the advanced study, which I will dwell on briefly because there's the latest data. There's a US pivotal trial, which is ongoing at the moment, which is a randomized study. There's the advanced 2 study, which is looking at the best practices with the best with the current generation of device in 100 patients from the best centers. There's a CERTAVI, which is a randomized trial comparing it to surgical aortic valve replacement in intermediate risk patients. And there's a redo study looking at TAVI, the procedure, in failed prosthetic implants. There's also data from numerous registries, which has been put into a meta-analysis. Basically, the advance being the latest of the data which has come out, just to tell you that this is real-life implantation of CoreValve in real-world patient with severe aortic stenosis who are inoperable or extremely high risk, and in centers which have a heart team. 1,000 of these patients have been enrolled over a period of 1 year with an intention of a 5-year follow-up in 44 centers in 12 countries. All centers were experienced TAVI operators with at least 40 TAVI procedures under their belt. The clinical endpoints were on core lab analysis according to the Valve Academic Research Consortium data. So as in most studies, the mean age of these patients have been above 80 years. The logistic Euro score in most of these studies have been around 20. The ejection fractions have been usually around 50%. The mean gradients have been around 45, and the peak gradients have been 75 to 80. That has been uniformly, whether it's a registry or whether it's the advanced, this has been this case. The procedural success rate has been 98% with the device, and that's again been uniform in most experienced centers. Complications have been few, and we'll come to the complications. The MACE rates over a period of 30 days has been 8.3%, with an all-cause mortality ranging around 5%, and I think that's important to understand. Also important to understand is a stroke rate, which hovers around 3 to 5%. Going on to 6-month survival is 92% of all-cause survival. And when we graded by Euroscore, the ones with lowest Euroscore have a tremendous survival at 6 months of close to 93%. It's the ones with the high Euroscores which have an 83% survival. We look at a 6-month stroke rate of around 3.6%, therefore stroke-free survival of 96.6%. So stroke is realistically a problem. Even a 3.6% stroke rate is high in these patients. As we go on to pacemaker implantation as one of the complications in this advanced registry with experienced operators with the present generation of devices, we see pacemaker implantations with CoreValve ranging from 15 to 39%, though with the present generation of AccuTrack, the latest generation of device, the pacemaker implantation rates have gone down to approximately 25%. It is, by the way, related to the procedure. It is on the accuracy of implantation. It is as to how high or how low do you implant this valve below the aortic annulus. And what is important is that the pacemaker implantation does not affect the long-term outcome of these patients at that particular time. So this has been a very promising device. More than 20,000 implants with CoreValve have been done across the world. When we look at the long-term data, the 2- and 3-year survivals, the 2-year survivals from the meta-analysis of registries is close to 75%, 75 to 80%, and the 3-year survival goes to 70%. So in all, I would actually end by my talk by saying that this is certainly a TAVI procedure. Whichever device we now use, and there are 2 of these in major clinical practice, has actually transformed cardiac care. It is revolutionary. It is almost unbelievable. In fact, it was unbelievable 10 years ago when Alan Crebier, in one of my visits to Rouen, said that he was thinking of something like this. It is dramatic now. But there is also the humbling thought as we perform these in our country. We often have these situations arising out of not just TAVI procedures, but many other procedures as they come, advanced procedures as they come into the country. Reminds me of this very, very lovely cartoon. It says, the patient has shortness of breath, and now he has shortness of cash. That is the most humbling thought. We have to find ways to overcome these limitations. Thank you very much for your attention.
Dr. Seth, that was a wonderful overview of the procedure and the results from the ADVANCE trial.